Yeah, okay. Now, if you see this patient, my doctors were operating this patient, and then they suddenly called me. I said, "Are you guys joking? You want me to operate this patient now? Look at inside. I can't see anything." And inside it, there's a dropped IOL. There is bullous keratopathy, hazy cornea, but most important, see the ciliary staphyloma. On top of all this is the only eye of the patient. Okay? So it's a one-eyed patient. I said, let me see what I can do. And now you can see, so first thing is, I do not know where the pars plana is, and I have to be very careful in such situations. So what I decided now was, first fix a trocar AC maintainer. Once I fixed my trocar AC maintainer, I made my flaps, but look at the flaps, they are not 180 degrees apart. So I decided to make them 180 degrees apart. Here you see, I'm making a fresh flap. Once that's done, I now know I have to go in and lift the IOL. The problem is that ciliary staphyloma is the scary portion for me here. Because if I mess up that area, I can tell you one thing, there's no way I'll get out of it. That can start bleeding, and it's a no-win situation. My second problem is, can I see through this cornea? Obviously, it's very bad. I've taken off the epithelium. There is bullous keratopathy, but you can see the haze, and you can see the IOL lying on the retina. Once I've done a vitrectomy, the technique which we started by Ashwin, is called ECAL. What we do is a very simple technique. If you use a forceps to lift, you can produce a rupture of the retinotomy. So what we do is, we use the suction. Once we lift it by a suction, as you can see there, then I transfer it to a forceps. Through that hazy media, I've lifted it up. Now I've caught it, and trust me, if you are not seeing anything, don't worry, even I am not seeing. The worst part is, if you notice, this is a very tough lens to fixate, because as you will realize, it is a single piece, non-foldable IOL. Now, when you try to glue a single piece, non-foldable IOL, it's very tough, because if you bend a little bit, the haptic will break. And if that breaks, I have to explant. And if I have to explant, please understand, in this eye, I don't have any space to explant, because on the top you see the ciliary staphyloma all over. So I have to be very careful now. When you do such cases, please understand, a 3-piece IOL you can just flex and tuck. In a 1-piece non-foldable IOL, you have to withdraw and then tuck, which is what I'm doing right now. So here you see I've created the Chariot's pocket, and there I'm tucking the haptics in. So far so good. Now my next step is, I need to make this pupil smaller. So I'm doing the single pass 4-throw pupillasty. The media is very hazy. The media is very hazy, there's no doubt about it. So I'm using an endo illuminator from outside. I want to do some more of the 4-throw pupillasty, so that I know I'll land up with a bit of a pinhole pupil. So here you see, you've done one on the one top, one below, which will make my pupil much better. So simple technique of single pass 4-throw pupillasty is being done. Now once you do that, now I'm taking my vitrectomy probe, and I'm going to make that pupil with a vitrectomy probe bit decent and nice, because my main aim is, one, to make the size correct, about 1.5 to 2 millimeters. Second, in this case is, more important, I need my Purkinje image bang on. When you get a ciliary staphyloma of this size, I tell you what, I have no indication or inclination of how much is going to happen in the astigmatism, how much of higher order aberration this patient will land up. So I need my pinhole pupil to work. So now you can see my Purkinje image, P1, bang centered on the pupil. Here, once you have done that, and my Purkinje image is bang on track, now my next step is to close that little bit of gap behind. Because please understand, if I don't close these gaps, the air which will be in the anterior chamber will go back through those gaps, because there is no capsule. It's only an IOL inside that eye. There's a space in the peripheral area, and the air will go down. So now through this hazy cornea, I'm doing some more pupiloplasty to close up that defect which is there in the peripheral iris area. Not for a visual effect that much, but more important because I'm going to do a graft now, PDEC. Now you see I've just shifted my trocar AC maintainer, which is having fluid in the eye, to air. In such cases, I tell you what, you will be much better off with a trocar AC maintainer than a pars plana, because here I'm seeing my trocar exactly all the time. Anyway, now I've got air inside that eye. I now take out my Desmaze. Now I create my bubble. This is a type 1 bubble. We do only PDEC in Agarwal's there. So basically remember, you have Desmaze, endothelium and the Duas layer. It's about 25 micron. Then the air comes and stroma. So that's a type 1 bubble. The bubble doesn't go to the periphery. If it went to the periphery, it will be a type 2 bubble. But anyway, coming back to this particular case, once I prepare this graft, my next step is I have the sublux IOL. I lifted it up, fixed it. Now I take this graft after the pupilloplasty and I'm injecting it and unrolling it. Remember, ladies and gentlemen, this is the only eye of this patient. So there is no second chance for me, I know, in these cases, because it's going to be very tough to make this patient all right. This is the pre-op, one-eyed patient. We did the ECAL, we did the glued IOL, we did the photopupillasty, we did the pinhole pupillasty, and we did the PDEC. And now look at the same patient, pre-op, 1 month post-op, and you can see how the patient looks. So that's the first case which I thought I'll show you. Now I take you to another case. And let's see in this particular case how the situation goes. Now in this particular case, there was a small pupil. So this is an eye ring. It is made of polymethyl methylate, and you can see this. This is like a modification or of the Malugan ring. So I use this inside. It's green color. So look there. I'm using trypan blue for staining the capsule. But somehow I have not noticed my rhexis has run away. Now once my rhexis has run away, I have not noticed it at that stage. I say continue with the phacoemulsification. You don't have to be an Albert Einstein to understand rhexis has run away, hard cataract. With my surgical skills being so bad, I will develop a PC rupture. When I develop this PC rupture, as you can see just now, obviously the next step, there's no rocket science to understand, boom, gone, nucleus gone. So now the question is, I have a nucleus drop, obviously. Now question comes, what do I do? So you can see the rhexis has extended posteriorly there. So now I am in big trouble. I have a drop nucleus present. I have an eye ring present inside the eye. The next mistake I'm doing is I'm doing an IA, which I should not be doing. I should have gone for a vitrectomy system, because there's obviously vitreous coming. So I now fix my infusion cannula. Now a simple trick which I tell all of you when you have cases like this, just follow a simple trick. And that is very simple. I start praying. Okay? If you start praying, like I'm doing right now, and I'm doing my vitrectomy, and you pray and pray and pray, and you see my nucleus coming up, caught. The problem as a human being, we tend to get arrogant. So I stop praying. And when I stop praying, you see what happens is basically this. Once it drops. So answer, again start praying. So now again I'm starting to pray, and now you'll notice that nucleus again come up. Now I'm not leaving it for dear life. I'm bringing it on top. The thing is, how do I remove this nucleus now? So we thought, let's do the scaffold technique, which we published in the year 2012. And here you can see I'm using the 3-piece IOL, holding with the left hand the nucleus fragment. And you can see we first published it in the JRS, Journal of Refractive Surgery. Later on, we published this in the Ophthalmology Journal, where the basic principle is you bring the nucleus up anteriorly, implant the 3-piece IOL behind the fragment. Now, use the phaco probe and emulsify. If you have a rhexis, you can just put it in the sulcus or glue it inside. So once you see that IOL inside there, the next step for me is, you can see there, I'm now going to use the phaco probe and emulsify the fragments there. So this is the IOL scaffold technique. Once that is done, Now my next step is very simple. I have to simply transfer the haptic which is above the iris to behind the iris and glue it inside, and I should go home. The problem here is I did not realize there is an eye ring. So watch carefully now. My eye ring is getting locked. My haptic is getting locked onto the eye ring. So when I'm doing my handshake technique, it's getting locked. I'm not able to dislodge it from the eye ring. So I decided the next best method is to leave the haptic as it is. So now my one haptic is lying in the vitreous cavity. Now I'm going for the second haptic. I'm going for the second haptic now. Remember that if this haptic goes down, the case will be over because both my haptics will be down. So I'm doing this vitrectomy here, transferring the haptic from one hand to the other, catching it, pulling it out. So you can see the subluxed IOL there, caught and pulled out. Once one haptic is out, now I'll do the same for the second haptic. So here you see, catch it somewhere, transferring it from one hand to the other till you get the tip of the haptic caught and pulled out. So far, so good. Now my problem is to remove the eye ring. The thing is, when you do a removal of an eye ring or any of these rings, first dislodge them from the iris. Then you can pull it out. Here what I've done is I'm trying to pull it out without dislodging it from the iris. In the bargain, you'll notice in a second, here I'm trying to pull it out and I've created an iridodialysis. This is like going from the frying pan to the fire, and you can see here, now I've created a big iridodialysis. So now my next problem is, what do I do? So now I'm trying to dislodge the eye ring from the iris, from the pupillary margins, then I will try to remove it. Now in the bargain, if you notice, what's happening is, my eye ring is started to go down. And with that, if you notice, my haptic on your left is also getting nearly going back inside. So now I've got a multiple problem here in my hand. One, my eye ring is going down. Two, my IOL is again starting to sink. So I'm trying to bring that eye ring anteriorly, and when I'm trying to bring it, it's still not listening to me that much and going in posteriorly. So the next step for me will be to catch that, the haptic which is about to go down. So my assistant grabs it, I catch the eye ring before it goes down any further. Now what I have to do is bring this eye ring anteriorly out. Once it is out, bring it above the iris. Now I take the same one which I used to inject it to explant the eye ring. And you'll see me doing that just now in a second. So here you can see I'm using the same injector and I'm explanting this eye ring out. Once my eye ring is out, remember I lost my haptic again, so I'm making more of an anterior sclerotomy to get more haptic externalized. Here you can see I'm going to make an anterior sclerotomy. I already have an iridodialysis there, so I don't have a fear of creating an iridectomy there. I already have the iridodialysis. Now for the umpteenth time, again I'm going to catch that IOL haptic, catch it and pull it out. Here you can see me catching that haptic, pulling it out. Now all I need to do is tuck the haptics in. Before you do the tucking, please assess how much haptic is externalized. Look at the amount of haptic externalized, it's a lot. If that gets stuck, there's no way this lens will subluxate again. But remember, I still have to fix the iridodialysis. So the technique we have used nowadays is the trocar assisted iridodialysis, which is a modification of the hangback technique of Michael Snyder. So basically the principle is to use two double arm proline needle sutures from the iris to the sclera and repair it. Once my iridodialysis is repaired, now I will apply the air, check if there is any optic capture, pull out my infusion, apply the glue and seal everything down. That's the case post-operative day 1, ladies and gentlemen. And now you will see the same case 6 months post-op, the patient vision improved to 6.6. I'd like to thank Kumar for inviting me for this lovely course of his. Thank you very much, Kumar.
That was fantastic, Amar. I mean, you had the patience. I would have really got confused. I mean, the ring and then their iridodialysis and the lens going in. I mean, only you could have. I was worried in between. You'll ask me, what will you do, Kumar? I would have just said, call Amar. For me, it's very easy. But I mean, every time we see his videos, there's a lot to learn. One thing is for sure that you can handle scenarios we are iatrogenic, and the way he shows them is unbelievable. So a lot of